Hello, everybody, and welcome to this session 6 on gender and sexuality. We have 3 speakers here today, Linda McAuliffe, Megan Oglesby, and Maaret Meriläinen. And if you could ask any questions or make any comments in the chat, and then after each speech, perhaps because I think we'll have enough time, we can just have a few questions for each speaker. And then if we have any extra time at the end, we can also have some more questions. So I'd like to introduce Megan Oglesby, who is going to talk about exploring dementia, avoidance by LGBTQ plus older adults in Ireland, a mixed method study. Megan Oglesby has a Master's of Science in Psychology from Dublin City University, and she's currently working as a research assistant in NUI Galway, researching how to improve care for LGBTQIA plus people with dementia. Megan is also working on a randomized controlled trial to test the efficacy of a cognitive-based intervention to improve the cognition of people with multiple sclerosis. So now we're going to have the recorded presentation from Megan.
Hi everyone, my name is Megan and this presentation is about a mixed method study that explored dementia service access and avoidance by LGBTQI older adults in Ireland, which was presented as a master's thesis to Dublin City University along with Dr. Louise Hopper as the principal investigator. So very quickly, I'm going to go through a bit of the background literature and give you some context, and then I'll get into the study and our findings in more depth. So very little research has been conducted in the area of LGBTQIA people with dementia, who are often described as being invisible, partially due to the assumption of heterosexuality or asexuality in older adults. LGBTQIA people are also more likely to develop conditions linked with the development of dementia, such as HIV, cardiovascular disease, and depression, which means they might be indirectly more at risk of developing dementia, possibly. There is evidence that older LGBTQIA adults with dementia have experienced discrimination in care contexts, for example, being denied places in nursing homes, that their partner is often the key person who protects them for potential discrimination. Heteronormativity, or the assumption that everyone is heterosexual, has been linked with the avoidance or delayed use of healthcare services, as well as non-disclosure of gender identity and sexualities. And this is reflected in the fact that 40% of older LGBTQIA adults in Ireland don't disclose their sexuality or gender identity for fear of discrimination. But non-disclosure can be difficult for people with cognitive difficulties. Several studies have reported that sexual and gender minorities are more likely to experience isolation in older age, making them more vulnerable to possibly abusive situations by unaccepting families of origin. They may also be less likely to have children and are more dependent on friends, their age, or partners to take care of them if they experience cognitive decline. And if they are avoiding services, then there might be more pressure or stress experienced by the caregiver. So this study aimed to examine how LGBTQIA people with dementia in Ireland interact with available dementia services and any barriers that might be present. We also aimed to examine caregiver stress as a result of reduced service utilisation by LGBTQIA plus people with dementia, if this is the case, and to explore recommendations for LGBTQIA plus friendly dementia services. So for this, the survey, we also had 3 hypotheses. So 1, perceived heteronormativity is a barrier for LGBTQIA people with dementia to access appropriate dementia care service in a timely manner. 2, older adults who have had previous negative experiences in healthcare settings due to their sexuality or gender identity will be less likely to avail of healthcare services in a timely manner in the future. And 3, primary caregivers of people with dementia will experience more caregiver stress if the person they are caring for is not utilising available services. So to achieve this, we used 6 online interviews and an anonymous online survey. We also noted that dementia services have been drastically affected by COVID-19, and as COVID-19 was a barrier for everyone, regardless of sexual identity or gender identity, from accessing these services, we needed to control for COVID. So we did this by only recruiting people who had been diagnosed or in their caring role for at least 1 year prior to the COVID-19 outbreak in Ireland. So we interviewed LGBTQIA people with dementia and primary caregivers of LGBTQIA people with dementia. We interviewed professional dementia care providers as well. and also LGBTQIA people over the age of 50 who do not have dementia nor care for anyone with dementia. And we believe this group could tell us about LGBTQIA plus healthcare decisions in general and whether prior positive or negative experiences with healthcare could influence future healthcare use. So we found 6 themes from these interviews, and the first was individual differences and LGBTQIA specific needs. So essentially there was an emphasis by most interviewees that although dementia is a very unique experience for every individual, and though LGBTQIA plus people are affected by the same symptoms and difficulties that affect heterosexual and cisgender people, that LGBTQIA people also have a unique set of needs depending on their specific identity within that community. And both in general and in the context of caring for someone with dementia. So secondly, we found that the saliency of symptoms or other more pressing issues in an individual's life, or the saliency of symptoms, will have an influence on whether they access services or not. So for instance, someone we interviewed who wanted to quickly get involved with dementia services could not, because he recently migrated to Ireland from the United States, and due to our housing crisis in Ireland, he could not secure suitable accommodation in a timely manner, and he had to put off accessing dementia services to focus on getting accommodation. And the caregiver participant also mentioned that they hadn't really used services for about 4 years because his partner's symptoms, he didn't feel like he needed them at that point. And when his symptoms did begin to increase more drastically about 4 years later, they began to use the services, very simply as that. And he did mention that using these services made him feel supported and relieved. So thirdly, feeling out of place was another common thread throughout the interviews. Gay participants in particular felt uncomfortable in predominantly heterosexual spaces and felt as though there should be more information on where to meet other LGBTQIA people going through the same thing that they were going through. One participant also noticed that he had been excluded from being considered as partners next of kin until their civil partnership, which made him nervous about any upcoming health concerns even before his partner's dementia diagnosis. So listening to LGBTQIA people as experts was also emphasised to ensure person-centred experience in care services and reducing negative experiences such as, well, one example in our own participants was that she was called a name that clearly didn't correspond with her gender and the gender she was presenting as. In a full waiting room of people. This was early on in her treatment. It wasn't a dementia treatment. And it could have influenced another person to not continue with care or to avoid care, but it didn't discourage this person in particular. It was also mentioned that if LGBTQIA groups and dementia services work together, it might help to increase knowledge of the LGBTQIA community in dementia care and improve the services. So finally, explicit communication of acceptance was the last theme, and it was one emphasised by the majority of participants who believed that if services advertised the fact that they were LGBTQIA friendly, and if staff had the training to be LGBTQIA inclusive, then LGBTQIA people with dementia and their service and their caregivers would have no need to worry about whether or not to disclose or whether they'll be experiencing discrimination in a service. So at around the same time that the interviews were being conducted, we were also running a survey for LGBTQIA people with dementia and primary caregivers of LGBTQIA people with dementia, LGBTQIA people over the age of 50 who don't have dementia and were not caregivers, as well as non-LGBTQIA people with dementia and caregivers. So this group was mainly to assess caregiver stress with relation to the utilisation of services in comparison to the LGBTQIA group. This survey had multiple choice questions, Likert scales, and open-ended questions that were analysed using thematic analysis, which is how we analysed the interviews as well. However, due to low engagement, only a small number of participants took part in the anonymous online survey, and only a total of 13 were completed. However, healthcare providers were also reported LGBTQIA people didn't report health anxiety and had mostly positive healthcare experiences, which is great. However, healthcare providers were also reported not to use the correct pronouns and names for transgender patients. There were a few visible displays of LGBTQIA services or acceptance in services, and participants were often assumed to be heterosexual. So no LGBTQIA participant had been denied healthcare procedures due to their sexuality or gender identity. Less than one half knew of an LGBTQIA friend who had been mistreated in a healthcare context, and the majority had not had their health concerns dismissed due to stereotypes linked with their gender identity or sexuality, and had been treated with respect in a healthcare context. So that all sounds very good. So moving on. So caregivers expressed feeling stress as assessed by the Kingston Caregiver Stress Scale. However, there was no difference between the stress experienced by caregivers of LGBTQIA people with dementia and non-LGBTQIA people with dementia. Initially, it looked like there were some differences between service utilization by caregivers of LGBTQIA people with dementia and caregivers of non-LGBTQIA people living with dementia. However, this difference that you see here was not statistically significant, meaning we can't say that there was a difference between the utilization of the two groups. So previous negative experiences with healthcare based on sexuality and gender identity was also not found to be a predictor of service avoidance. However, due to the very small sample size, there is increased chance of a type 2 error here in these results, and which basically means that if you have a very low number of participants, it can look like there's no difference between the results, where there actually might be if you had a larger sample, but it's very hard to say. And so further research with a greater sample size is needed. There's also there is a possibility that people with dementia are utilizing services and are successfully not disclosing their identity, which is contrary to previous findings about the difficulties faced with non-disclosure in people with dementia. But again, further research is really needed here. So the open-ended survey questions gave us some interesting findings. So participants suggested that there needed to be awareness training for health professionals in how to interact with older LGBTQIA people, and this training should be throughout the person's career or part of their qualifying process. And despite one person declaring his sexuality on multiple occasions, healthcare professionals still kept referring to his sister as his wife, which is a fairly extreme example of heteronormativity and probably very frustrating too. Like the interview participants, they also experienced the need for visual information about LGBTQIA services or health information specific to the LGBTQIA community in public healthcare spaces. Additionally, it was advised that Ireland's dementia services should be more inclusive and follow international models that have services that are specifically for LGBTQIA people with dementia and their care partners. So in conclusion, I'll just go back to our main aims. Though statistically we did not find significant results for our hypotheses, we did find that barriers such as heteronormativity could contribute to service use avoidance if the purpose of the service is socialization, that embarrassing situations such as being dead named and socioeconomic issues such as housing crisis in Ireland could contribute to service avoidance. Caregiver stress did not appear to be related to service utilization or avoidance statistically, though in our interview we did find that a caregiver participant found that he was very relieved when they began to utilize services as he felt supported. There was also many recommendations made by participants, including training for staff, much more visibility, following international models for caring for LGBTQI people with dementia, LGBTQIA specific socializing services, explicit communication of acceptance in leaflets or websites by dementia services and LGBTQIA services working together to create more knowledge and more friendly LGBTQI friendly environment. So thank you so much for your time. I'll answer some of your questions now. I'm just going to hover over the references just so you can see them and pause them there. Thank you very much.
Thank you very much, Megan. That was really good. I did have one question for you. You mentioned that the importance of explicit communication of acceptance. And I was just wondering, to what extent is there any guarantee that when there's a communication of acceptance that the staff will and professional carers will actually be accepting, whether that's genuine, and how that relates to the kind of the huge kind of the heteronormativity and unintentional slights and that kind of thing?
Yeah, that's a great question. I think you can't just have the visual cues or the visual signs of acceptance like rainbow flags or different things around to say that you're LGBTQ positive and then have staff that aren't. You have to sort of back that up with training. I think that was a point that was emphasized by the participants and other research as well. It's like you kind of have to take a two-pronged approach with it, in that a lot of research has suggested that staff just need more LGBTQIA specific training, and that it should be mandatory or a part of the the qualifying process, depending on what you're working as, or as part of just the mandatory training in your job. Mandatory for a couple of reasons, that people who maybe hold these biases would avoid it if it wasn't mandatory, and just because it's often ignored or something that people don't necessarily consider. Heteronormativity can be accidental, and it can just be what some people think is the default, and we'll just start referring to everyone as assuming that they have a husband when they're actually a lesbian woman or something like that. And with so you really have to take a serious approach to it. I think a participant mentioned that it can't just be, I suppose, very on the surface training. Like everyone in let's say if it's a care home should receive this training, not just the care staff. It could even be actually a participant in the study that I'm currently doing mentioned that it should be from the CEO to the cooks in the kitchen should have this sort of training to make everybody aware, and to make sure that everyone is, I suppose, treated as though they're human beings and treated with respect and dignity, which is so important in particularly end of life care and dementia care. I hope that answers your question.
Yeah, very good. Thanks a lot. I just noticed there are a few comments coming. Very interesting work, Megan. Well done, Megan. Really important work. So it's definitely making an impression, your work. Just another quick question. You mentioned a survey that it was very difficult to get enough responses, and that you said you had 13 in the end. What are the challenges to actually reaching people in addition from minority groups, for example, minority ethnic groups, but also other groups?
Yeah, I think it's about safety. So a lot of people might be safe to come forward, and they might be suspicious, say, well, why are you doing this research? And obviously you should have an explanation that in your advertisements and things like that, and that might help. It might also, people might not be comfortable talking about it at all, or maybe may not be ready about it. There could be intergenerational differences in how this is, like how people want to talk about these things, or they may consider it very private. COVID wasn't helpful, like everywhere, like the social groups, a lot of social groups were closed or online basically, or there may not have been as much interaction online as well. Yeah, it was a difficult process to try and recruit, and it's even in the current study I'm doing, which is the same population, it's a bit better. We've gotten more people, but again, it is a difficult population to recruit for. I think as well, when it's LGBTQ people with dementia, and if you're not just recruiting LGBTQ people with dementia who could have gone back into the closet if they're in a care home, or if they don't necessarily know if they're in a safe space or not. We were also looking at LGBTQ older adults, and it's possible that older adults just don't want to think about dementia, no matter what demographic you're from. So there's a few possible factors that are at play, could be, I think, affecting. I think as well. Sorry to keep going on.
No, that's fine. Please continue.
Oh, no problem. I think as well. I've read a few things that suggest this, and I've spoken to a few different researchers that have suggested this. That regardless of the project, it's difficult to recruit at the minute as well during COVID, because of possibly Zoom fatigue, or just, I don't know, fatigue in general, just COVID fatigue. So people not really wanting to engage in stuff. But I would say something that could help is perhaps looking at maybe an ethnographic approach, or where you don't necessarily need a huge layer of participants. Like if you're looking at doing a multiple regression, you obviously need hundreds of people, and that's probably not going to happen in a population like this. Maybe I'm wrong. Maybe there'll be like speakers in a few minutes that say otherwise. But yeah, I think it's about being as open and honest about what the research is for, and trying to get a broad scope, going through all of the organizations you can, to try and reach people. But it is difficult.
Yeah, it's a huge challenge. Yeah, I was just interested. Yeah, thanks a lot. Well, if there are, just check there are no more questions this minute. No. So I'll move on to our next speaker, but just a message to the audience: if anybody would like to still ask any more questions to Megan, there's still time, and we might have a little bit of time at the end, so please don't hesitate. So thank you, Megan. I'm now pleased to introduce our next speaker, Maaret Meriläinen, who's going to talk about the sexuality of people with dementia and their spousal caregivers. Maaret Meriläinen is an occupational therapist and a sexuality counsellor. She's worked in the Memory Association of Oulu region, Finland, for the last 15 years, and the aim of her work is to develop new ways to support a relationship of people with memory-related disease and their spousal caregivers. And in addition, she's an entrepreneur providing training for professionals and personal guidance for older people.
Hi everyone and welcome to Memory Association of Oulu region in northern Finland. My name is Maaret Meriläinen and I'm working as an occupational therapist and sexuality counsellor with people with dementia and their spousal caregivers. The aim of my work is to develop, together with my colleagues and elderly couples, new ways to support my clients' marital relationship and a meaningful everyday life. More than 100 couples are taking part in varied activities of Kaarna project in this autumn. Kaarna is funded by Ministry of Social Affairs and Health. Couples with dementia or memory-related disease, as we say here in Finland, face more sexual dysfunctions than other peers, but still they seek less help with their problems. Sexuality is perceived as a private and also a little bit shameful affair that doesn't belong to others. As a sexuality counsellor, I meet most female caregivers. It's not so common that spouses come to meet me together. Unfortunately, public discussion about sexuality of people with dementia is still very problem-orientated. We might talk about hypersexuality and other problems, but totally forget many welfare effects. It would be so important to share a positive information and effect on attitudes. Now I'm going to tell you a little bit about sexuality and dementia survey which I made in 2019. With this survey I wanted to find out what kind of sexual activity couples with dementia have, how they feel about their sexuality and what kind of worries they might have. The survey had a total of 14 questions. One of them were so-called free words, where respondents could write their own thoughts freely. It was possible to answer the survey both digital and on a paper form. I got responses from 22 people with dementia and 52 spousal caregivers. There were 31 men and 43 women. The majority of caregivers were women, while the majority of those with dementia were men. Almost half of the respondents were aged from 70 to 80 years old. About a third of the respondents were in the early stage of dementia. Diagnosis of memory-related disease had got less than 2 years ago. I was happy with this number of the respondents, and particularly I was pleased with the responses of people with dementia, because their voices are often not heard in such surveys. Then something about results. When monitoring the results of this survey, it's good to note that the number of caregiver respondents and the number of respondents with dementia are different. Therefore, the results cannot be generalized. But I believe that we still get interesting information about sexuality through this survey. We can't go through all the results now, but I have picked out a few of them for a closer look. If you are interested, you can ask me a full report by email, but I'm so sorry, only in Finnish. About 75% of people with dementia and more than half of spousal caregivers consider sexuality an important part of the well-being of a relationship. People with dementia perceive sexuality as a more important part of a relationship than spouses. Intimacy can be a huge strength for both, especially in the early stages of dementia. Sex life of respondents was described as involving a lot of hugs, kisses and being close. The answers emphasize intimacy and affection. About 30% also had coitus. Caregivers use more sex aids and masturbate more than their partners. One question of survey was what changes have spouses experienced in their sexuality and marital relationship. Although physical problems also occur, clearly greater inconveniences are experienced in the mind. The responses of spouses with dementia were mainly related to their own emotions and physical changes, while the responses of caregivers were more diverse. Here are a few direct quotes. When my husband started to use Viagra, sex became an accomplishment. The mood disappeared and I didn't want that anymore. More than a year without sex at home. I have met several men, but they have not been my partner. Now I have met a wonderful man who understands my situation and doesn't put pressure on me for anything. A new intimate relationship came into my life when my husband had a middle stage dementia. I was worried, but my psychologist encouraged me. The relationship has brought into my life not only a good sex, but also the opportunity for a normal life. Sex brings us closer. Life is here and now. Dementia has changed my manhood. Aging changed my own sexuality, for example, changes in vagina. I can't have sex. My spouse doesn't know who I am, and it has taken my desires into sex. My spouse can no longer consider my needs in sex. My spouse has been violent also in bed, hitting, kicking, suffocating with a pillow, tying hands. And then he asks why I don't want him. This female caregiver wrote that this kind of situation has lasted almost 4 years. I'm so sad and really worried also that too many people might need help, but they don't know how and they don't know where to get it. This is one reason why it's so important to do this kind of survey and share the information. The obstacle to seeking help was both shame and insecurity, but also the situation in the relationship and the disagreement between spouses. Sometimes the obstacle is the lack of own resources. You might just be too tired. In addition, many don't know where to contact for help. As many as 25% of caregivers hadn't received information about sexuality, even if they needed it. It's true that it's not easy to find help. There are only few sexual counselors or therapists in Finland who specialize in the elderly or couples with dementia. 30% of respondents hoped that professionals like physician or nurse would start to talk about sexuality. More than 20% would be ready to talk about sexuality also in peer group. The spousal caregivers see their partners differently as the disease progresses. Their responses also highlighted that caregiver may have intimate relationship with a new partner which causes both guilt and joy. Actually, this is the most common subject when caregivers come to meet me in sexuality counseling. More than 40% of the caregivers who responded to the survey consider the possibility of falling in love with another person. Almost 40% of caregivers were wondering how long can they have sex with partner with dementia. They would like to know when it's not okay anymore. 57% of people with dementia and 54% of spousal caregivers were worried if their sexual needs and longing for intimacy will take into account when disease progresses. Now I have almost used my time. Based on this survey, many other studies and my own experiences, there should be more talk about sexuality. The right information helps to live a meaningful everyday life together and it encourages to seek help when needed. Sexuality counseling should be available to people with dementia and their caregivers. It is important for the helper, and I mean also caregivers and professionals, to have knowledge of both sexuality and dementia. It is essential to talk and give opportunity to talk about sexuality at different stages of dementia. Thank you.
Thank you very much. That was great. We had a few reactions in the chat. Somebody was saying that there were very good quotes, and so that would be very useful, I think, for people to look at your presentation afterwards as well. And also that these very important topics which are often not discussed in some countries. And one of the questions, somebody's asking, were there any issues with the response rate to the survey with the questions about sexuality?
I'm a little bit worried about my English, but if I
don't worry about it.
The questions right. So it's I think that many of those respondents were quite okay with their sexuality. So it was quite easy to answer the questions. I would like to know more about people who don't want to talk about sexuality, but it's not so easy to have those answers. Sexuality and sex life, it's really hard subject.
Do you notice any difference in the age of the people involved with regard to the difficulty talking about sexuality? Or is that not really an issue?
I think that it's I'm sorry, probably I can't. I have to tell you that I have a COVID-19 right now, and I'm not so okay. So
yeah. Could I ask?
try to focus.
Would you like us to come back at the end, perhaps give you a little bit of a break for your voice?
No, it's okay. I can read these questions here.
Because there was somebody else who was asking about how, if spousal care is discussed, how they deal with differences in sexual desires.
That's a really common subject when they come to speak with me in sexuality counseling. It depends on person. We always have tried to find some solution which is okay exactly to that person and her spouse. There is no recipe book, which is okay for everyone.
Yeah, that's true. And you mentioned earlier when you were speaking that a lot of people don't know where or how to get help. Do you have any recommendations as to any kind of a system that you think would really help people, or what kind of system is needed?
Some places like memory associations, for example, it's really easy to go there and talk about many kinds of things. Especially I'm working in memory association, and those people, it's really easy to come to see me, and many people go to the doctor, for example, physician, but they don't have so much time to talk about many kind of subject. So I don't know the situation in other countries, but here in Finland, we need so much more sexuality counselors or sexual therapists.
Yeah,
we don't have enough.
And is in your country, do you think that is there any problem with kind of stereotypes about older people and sexuality and people with dementia?
I think that like other countries too.
Yeah. Well, okay. Well, so I don't think we have any other new questions in the just checking. No. So for the time being, then we'll move on to the next speaker. If we don't speak again, I do hope that you make a good recovery. So thank you very much. And so we're now going to move on to our last speaker. It is Linda McAuliffe, and she's going to talk about sexuality and cognitive impairment in residential aged care, staff perspectives. So Linda McAuliffe is a research fellow with the Australian Centre for Evidence-Based Aged Care, a research centre of La Trobe University in Melbourne, Australia, and she's also a registered psychologist. Her main research interests include the psychosocial health of older adults, including older adults with dementia and their family caregivers. So nice to see you, Linda, and over to your presentation.
Hello, my name's Linda McAuliffe, and I'm a research fellow from the Australian Centre for Evidence-Based Aged Care at La Trobe University in Melbourne, Australia. And today I'd like to share with you the findings of a study we conducted as part of a broader program of research on intimacy and ageing in aged care. And firstly, I'd like to acknowledge our colleague Maggie Syme from Kansas State University for developing the vignette that was used in this study. Lifelong interest in sexuality has been well established in older adults, even following admission to residential aged care. We know that sexuality and its expression have numerous benefits for older people, both physical and psychological, and can provide much comfort during what may be an otherwise difficult time. Yet despite this, residents' right to sexual freedom is commonly overlooked in this setting. And there are numerous reasons for this oversight. Staff might hold ageist attitudes to sexual expression in later life. They may feel uncomfortable discussing sexuality, or they may discourage resident sexuality because of the resident's family who may disapprove. Structural barriers such as limited availability of shared rooms and the challenge of reconciling public and private spaces may also be pertinent factors. Concerns regarding potential litigation are also relevant, particularly when dementia is involved. Sexuality remains a complicated issue to navigate for care providers, family, and older residents themselves. And this is why it's so surprising that there's a notable lack of policy regarding sexuality and older adults living in residential aged care. In Australia, less than 1/4 of facilities report having a written policy regarding resident sexual expression. In the US, almost 2/3 of nursing homes do not have a policy addressing resident sexual activity, despite reporting a high prevalence of issues related to sexuality in older residents. And in the absence of policy and education, staff have been found to be more likely to view later life expressions of sexuality as non-normative and problem behaviours. We believe that those charged with providing quality care for older adults must have adequate understanding and policies to help guide decision-making in this complex area of practice. In an initial step towards this goal, the aim of this study was to identify decision-making factors that lead to the existence of current local informal policies about sexual behaviour of older adults living in residential aged care. So our study aim was to answer the following question: what factors influence residential aged care staff when they make decisions regarding intimate relationships and sexual expression among residents? This study involved a nationwide survey of all Australian residential aged care facilities. A postal survey was sent to all 2,931 facilities as listed on the Australian Government website, and the survey was addressed to facility manager or nurse unit manager rather than centre directors or administrators due to their experience and knowledge of coalface issues. The survey was sent out and then a reminder was sent after 8 weeks, and participation was voluntary and anonymous, and return of the survey was interpreted as consent to participate. We first piloted the survey with a small group of health researchers and clinicians with backgrounds in nursing, psychology and public health, and with expertise in survey design, quantitative and qualitative analysis, and/or aged care. And the purpose of the pilot was to collect feedback on both the survey layout and content, with refinements made to remove any ambiguity from the survey questions and to improve readability. The survey was divided into 2 main sections. The first section asked a series of demographic information questions regarding the recipient and the facility in which they worked. And the second section of the survey presented a fictionalised vignette of Norm and Carol and their relationship, which we'll see on the next slide, followed by a series of statements. Respondents were asked to rate on a 5-point Likert scale how much they agreed with each of the statements. The initial statements were: these intimate activities between Norm and Carol should be allowed to continue, and you would intervene in Norm and Carol's case. This was followed by a series of 10 questions, each of which presented a variation to the case study as originally presented, either in terms of level of cognitive impairment, family involvement, marital status, or degree of intimacy, with respondents again asked to indicate, using the 5-point Likert scale, how much they agreed with each statement. So this was our vignette, Norm and Carol. Originally, it was developed by Maggie Syme from Kansas State University, and we adapted it for the Australian context. Norm moved into an aged care facility a year ago after his health deteriorated and he required more care than the family could provide at home. Norm has some symptoms of dementia, mild cognitive impairment, as he forgets names of his usual care staff, has difficulty recalling his daily activities to his children, and has started to unknowingly repeat the same stories to the same people. Norm and Carol are companions. Carol came to the facility around the same time as Norm. She was admitted there due to declining physical health and has no cognitive impairment. Since she came to the facility, Norm and Carol have developed a close relationship and they are rarely seen apart. Norm and Carol are observed to enjoy each other's company, and Norm appears very happy when he is with Carol. He always asks for her to be by his side. Staff have observed that Norm and Carol spend much of their time together. Carol holds hands with Norm, cuddles him, and occasionally gives him kisses. We received completed surveys from a bit over 500 facilities, and this represented a 19% response rate during a time impacted by national bushfires and floods. Characteristics of respondents are presented in this table here. As you can see, respondents were mostly female, mostly married or partnered, and had an average age of 51 years. They had worked in aged care for about 16 years on average. The majority were facility managers. Most reported having attended education on sexuality in older people and having had addressed a situation regarding resident sexuality or sexual activity. In terms of characteristics of the facilities from which the respondents worked, most respondents represented not-for-profit facilities, with an average of 80 residents and with around half with dementia. Over half of the respondents reported that the facility in which they worked had written policies on sexuality. Fewer had written policies on sexual health or sexual behaviour. And it's interesting to contrast this with our findings from a few years ago, which indicated that less than 25% of facilities had a written policy on resident sexuality. With respect to whether or not the intimate activities between the fictionalised couple should be allowed to continue, the majority of respondents agreed or strongly agreed that they should. Only 10% of respondents indicated that they would intervene in the case as presented. However, when we varied the case study by presenting additional information which changed the scenario, the respondents reported that they were much more likely to intervene in Norm and Carol's relationship. Firstly, we can see that level of cognitive impairment influenced decision-making about the hypothetical case. When we increased Norm's level of cognitive impairment to moderate, remembering that Carol has no cognitive impairment in the vignette, respondents increased their likelihood of intervening. Similarly, when we changed the scenario so that Carol had moderate cognitive impairment and Norm had mild cognitive impairment, respondents were more likely to intervene. If both residents had the same level of impairment, respondents also were more likely to intervene. Now, if we look at level of family involvement as a factor, we can see that this also influenced responses, with a sizable proportion of respondents, 40%, indicating that they would intervene if Norm was married and had a wife living in the community. Similarly, if Norm's family expressed disapproval of the relationship, staff were more likely to intervene, and less so if neither resident had family who visited the facility. The level of physical intimacy was also a factor that influenced decisions, although to a less extent than cognitive impairment or family involvement. Interestingly, sexual orientation history was found to influence views on whether to intervene in the relationship, as was whether Norm was exhibiting distress. And in this slide, I have ordered the statements in terms of scenarios where staff reported they were most likely to intervene. And we can see that level of distress was a major deciding factor, followed by whether Norm was married to somebody else. This was followed by family disapproval and increased level of cognitive impairment. So what can we take from these findings? The vast majority of respondents were in favour of Norm and Carol's relationship continuing. A minority of respondents said they would intervene. However, when contextual factors were revealed, respondents were more likely to intervene, particularly if a resident was distressed, if a resident was married, if a resident's cognitive impairment was more than mild, or if the family disapproved. This study found that aged care staff use different pieces of information to inform their decision-making when it comes to resident intimate relationships. Staff views became more conservative when cognitive impairment increased, family disapproved, or the resident was married. And this suggests that informal policies guide current practice, despite over half of facilities reporting to have a formal written policy. These findings support previous research that suggests current practice is too often based on personal values and uninformed views and cultural norms and taboos, rather than a sound evidence base or a person-centred philosophy. And it highlights the need for formal policies that respect residents' right to sexuality while guiding staff as they navigate this complex area of practice. Thank you.
Thank you very much, Linda. That was really, really interesting. I just wanted to ask you about, you mentioned a few times the issue about the family disapproving of a sexual relationship. Could you say a little bit more about how that works out in the healthcare setting with regard to kind of the ethical aspect and the legal aspect of that?
Thanks, Dianne. I think I think families, it's such a tricky issue, isn't it? Because families have the best interest of their, well, they'd like to think that they have the best interest of their loved one in mind. And it does put the health professional in a tricky position of whether, you know, I think what these findings show is that when family is vocal, then that's hard to ignore. If family's less present, then perhaps things, you know, are managed in a different way.
Yeah.
Yeah.
Yeah, it's probably very difficult for the healthcare staff, especially when they're kind of stuck between the family and wanting to respect the wishes of the people involved, which is they obviously have a right to. Another issue you mentioned was you said right at the beginning that there were reported issues about non-normative and problem behaviour. Was there any difference, or in general, is there any difference between behaviour of men or of women being described as problematic or inappropriate in the healthcare?
Not in this piece of research, but yeah, more broadly, there's evidence to suggest that particularly older men are more likely to be, you know, labelled as a dirty old man, or, you know, whereas women are kind of you know, not seen as sexual as perhaps their male counterparts. So yeah, that's definitely a thing.
Yeah, and a lot of the people who so kind of the vignette is about a heterosexual couple, isn't it? And have you done any studies or research on non-heterosexual couples with regard to the sexuality?
But it's interesting. Originally, the vignette, there were the original design incorporated several vignettes, but because we know that this area of research is notoriously difficult to recruit respondents, you know, survey respondents for, we decided just to keep it, to simplify it and go with the one vignette at this point. I did think it interesting that that I think about 18%, when you provided some context about maybe their sexual orientation was different than what, then it was different previously, well, sorry, not different previously, but recognised previously perhaps, then, you know, people were more likely to intervene if they had that information about a person's previous sexual history, which I think speaks to the need for assessment of sexual health and sexual needs and preferences on admission to residential aged care. Although I think we also need to be careful when we use the word assessment that we don't mean we charge in with a, you know, a tick sheet and interrogate the person, but that we, you know, we at least give them the opportunity to discuss their needs, which is, I think, what, you know, Maaret spoke about.
Yeah, I realise I'm asking all the questions, but hang on, just check the chat. Perhaps do any of Megan or Maaret, or do you have any questions you'd like to ask each other, because we're on the same topic here? Is there anything you'd like to share or ask? I'll put you on the spot there.
I have one for Maaret. I was wondering, how do people find you? Do they usually, is it referral through the GP? Or how do they know how do they link up with you? How do they find out about you?
Sorry, are you asking from me?
Yes, sorry. Yes, how do your couples find you?
We have in this our memory association, we have more than 900 members, and of course social media and articles in magazine, or I have been in radio or TV or something like that. I have to do that work all the time, that people know that I'm here and they can come to meet me.
Okay, I'll just check again, just a minute. No, well, we don't have any other questions from the audience. So I'd like to thank all you all for your very interesting speeches, Linda, Megan and Maaret. And I think that if anybody has any other questions that they'd like to send to us, we'll pass them on, and we hope that this conversation will continue. So thank you very much. And thank you to the audience for attending this session. And I hope you enjoy the rest of the conference and keep safe. And Maaret, make a good recovery.